Alright, this is Brian Wormers, and on this lecture we're going to talk about nursing care of patients with brain disorders, and particularly seizures, related to medical surgical nursing for the University of Sioux Falls. So, some of the things we're going to talk about is how to assess that patient with seizure disorder, talking about acute seizure activity and what we need to have for priorities as nurses, and then talk about interventions and collaborative management for those patients with seizures. So realize that there's lots of different types of seizures, and so while you might be familiar with what the movies and TV show as seizures, realize that this is going to be varied. It could be everything from just a pause and kind of a gazing off to the full-blown tonic-clonic seizures that movies like to portray. So that generalized seizure is more of a tonic-clonic absence or atonic. That's where they drop and fall down. And so oftentimes you'll see patients that have been diagnosed with this type, that they wear helmets or different things like that. You can have partial, and so this could be complex, involves they might lose loss of consciousness or they might be aware with it. So if it's a simple partial seizure, they might, fully be aware that they're doing this. So other ways to describe it, idiopathic. So this is something that we don't know why it's happening, and this is the true form of epilepsy versus like a secondary seizure where they had head trauma and then that caused it, or there's a brain tumor and then that's causing seizure activity, or hyponatremia. So realize that idiopathic accounts for about half of all seizures, and so therefore, secondary seizures are about half of all seizures as well. So some of those things can include metabolic, like I said, the hyponatremia, acute alcohol withdrawal, electrolyte imbalances, high fever, stroke, head injury, tumors, things like that. So the International League Against Epilepsy, which I love that name. I think that is a great name of a group, and I fully support them. But this is how they classified seizures. So they could have focal onset where they're aware or unaware of their surroundings. And so motor onset or non-motor onset. They can have generalized onset, and then these motor activities, or absence kind of activities, or an unknown onset. So you might see that these classifications are what some people will use. So subjective and objective. So subjective, so how many seizures have they had? How long has it been going on? What do they look like? Anything, do they have an aura prior to it? And that aura can be something that they smell or see, or something that just kind of tips them off that something's not quite right. Are they taking any medications either for this or that could cause this? Any trauma, fever, substance use? Looking at those secondary forms of seizures. Any past medical history of seizures, or anything that could lead into seizures. Objective, so during a seizure, when did it begin? How did it progress? Changes in level of consciousness. The more that we can document this and know these kind of things, the more it will help those neurologists and those that deal with this understand what type it is and the best treatment modalities for that. So, did it start on the right side or the left side, or was it bilateral? Was it general tonic-clonic, or was it one particular area? Was it eye twitching? Was it lip smacking? Was it hand or leg? Did it progress? Did it change? Did it start and stop? Was there periods where they didn't have seizures in between there? Any apnea, cyanosis, loss of bowel or bladder? So all these things are important to document when you're caring for somebody that's had seizure disorder. Or a seizure, I should say. Diagnosis, so we'll do a CT and MRI to look for anything on the brain that could be causing this. That could be hydrocephalus, that could be tumors, that could be head trauma, head bleeds, different things like that. Laboratory, CBC, CMP, and toxins, so looking for anything that could be out of whack causing this. So an infection, bleeding disorder, electrolyte imbalance, ingestion or toxins, and then we can do an EEG. So that's where you hook all those different wires all over the head to look at the electrical activity of the brain and see how it's firing. So what do we do? Maintain an airway and protect them from injury. So if they're around anything that's going to hurt themselves, like if they're having a seizure while swimming or near a campfire or near a stove or anything like that, then we want to put them in a safe environment, and we want to make sure that they can breathe with this. So with this, we're often doing sideline procedures in case they puke during their seizure. We are having suction available if possible. We are not blindly putting anything in their airway. Do not put a tongue depressor there or a bite block or anything like that if we can avoid it. So collaborative care, protect from injury, we kind of talked about that. Generally speaking, we use the pad side rails quite a bit. Well, I haven't seen that used as frequently. We do try and get that bed as low to the ground as possible in case they were to fall out of it. Or some people might put the mattress directly on the floor so that if they fall off the mattress, that they're not going to hurt themselves too bad. Do not put anything in the mouth. You'll break teeth or they'll bite down on that. And then you could have a foreign object in the back of their throat that you can't get out because they clamp down. So just try your best to keep that airway clear. Loosen any restrictive clothing and protect your patient as much as possible. Do not restrain the patient. I have seen some patients with special needs that they've got some bone demineralization, they have a seizure, and they're actually able to have enough force that they actually break some bones. So really try not to restrain the patient. You're going to guide them while they're having a seizure more so than holding them down. Record the time and seizure that we talked about that before. When did it start? When did it end? What did it look like? We're going to do vital signs afterwards, perform neuro checks, keep that patient on the side. And another big thing on this that our slides don't necessarily say, but provide modesty for them. This can be really embarrassing for patients. We don't want them to wake up and have 20 different people all surrounding them looking at them. That's probably not in their best interest. Surgical management of this, so anti-epileptic drugs, of course. There's a wide variety of these. So depending on the type of seizures, there are a lot of AEDs, so anti-epileptic drugs. Often they do require monitoring, so looking for levels prior to and afterwards. So checking peaks and troughs and making sure that we've got an appropriate management of the medication. During an acute seizure, we might give some different medications like phosphine, Ativan, or diastat. Diastat's rectal. Lorazepam can be given in a couple of different ways, but usually we talk about IV form of this one. Same with the phosphine. Probably don't want to put any pills down their throat and try and get them to swallow if they can't physically do that. So there are a lot of specific anti-epileptics depending on the specific type of seizure that they have or the seizure disorder that they have. And so we can treat that appropriately. And I'm not going to ask that what type of med is good for what type of seizure activity. But realize that we do have lots of different ways to treat seizures depending on what they are. Collaborative management of seizures, of course, we can do some surgical stuff. So partial lobectomy. So if there's a lot of electrical stimulus that is causing discomfort and causing seizure activity, sometimes we can take that out. Vagal nerve stimulators with this one. Deep brain stimulus can sometimes help with this one. So we're starting to do some more surgical interventions for this. Patient teaching, of course, if they're on their meds, they should take them. Look for any side effects of this, like gum hyperplasia, or tiredness. Topamax can be one of those for causing some sleepiness. Phenytoin can cause like some gum hyperplasia and different things like that. So when they're feeling better, hopefully they're feeling better on these. Realize that they shouldn't stop it. It's all too common. It's like antibiotics. It's like, oh, we take them, then we feel better, then like, well, I'm better, I don't need the meds. Well, you're better because you're on the meds. And so if they abruptly stop it could lead into seizures again. They should be talking with their provider if they might be able to wean off of them eventually, or they might not. With their meds, also look for, drug-to-drug or herbal interactions. So just people are starting to take more and more over-the-counter things like St. John's wort or other stuff like that. And so if we can document that and look to see if there's any interactions with those medications, it's in your patient's best interest for that. Wear a medical alert bracelet or necklace for this one. And then, of course, follow up with, interdisciplinary care team members. Talk to family members as much as possible. In college we talk about roommates or, people that are living with them. How can they help this patient if they have a seizure? Where is their diastat? How do we give this? Know the laws about driving. When can they drive? When can't they drive? This is a provider decision in some states. So things that can set them off. So alcohol, excessive fatigue, bright lights, stimuli, different things like that. But providing balanced diet, proper rest, stress reduction can help with minimizing breakthrough seizures. That concludes this presentation on seizures. I know it was brief, but if you have any questions on it, please feel free to reach out to me.